Mechanical ventilation begins when spontaneous breathing fails and life support is required. The ventilator replaces or assists gas exchange by controlling pressure or volume. Assist control mode delivers every breath as a full ventilator breath. The patient may trigger extra breaths, but each one receives full preset support. This mode is used in shock, acute respiratory distress syndrome, pulmonary edema, and multisystem trauma. The ventilator fully offloads work of breathing. Volume control ventilation delivers a fixed tidal volume each breath. Minute ventilation equals respiratory rate multiplied by tidal volume. Inspiratory flow is constant in a square wave pattern. Once target tidal volume is reached, airflow stops abruptly. Increasing rate or tidal volume increases carbon dioxide removal. Decreasing either leads to carbon dioxide retention. Pressure control ventilation sets inspiratory pressure instead of volume. Tidal volume depends on lung compliance and driving pressure. Driving pressure equals plateau pressure minus positive end expiratory pressure. A value below 15 centimeters of water pressure is associated with better outcomes. In severe acute respiratory distress syndrome, inverse ratio ventilation may be used. Inspiratory time exceeds expiratory time and requires deep sedation. Dual control modes combine volume targeting with pressure limitation. The ventilator automatically adjusts pressure breath by breath. If lung compliance worsens, the ventilator increases pressure to maintain tidal volume. If compliance improves, it reduces pressure automatically. Patient effort can confuse adaptive modes and lead to dysynchrony. This may appear as the patient fighting the ventilator. Intermittent mandatory ventilation delivers a fixed number of machine breaths. Between them, the patient may breathe spontaneously. Synchronized IMV aligns machine breaths with patient effort. This improves comfort and reduces breath stacking. For example, 10 mandatory breaths of 500 milliliters are delivered per minute. Additional spontaneous breaths vary in size. Pressure support is added to spontaneous breaths only. It reduces work of breathing by overcoming circuit resistance. Typical pressure support starts at 10 centimeters of water pressure. It is adjusted based on tidal volume and patient comfort. As recovery progresses, mandatory rate is gradually reduced. The patient takes over more of minute ventilation. Daily spontaneous breathing trials remain the best method for weaning. They are superior to gradual mode reduction strategies. Pressure support ventilation allows full patient control of breathing rate. There is no set mandatory respiratory rate. Each breath is flow cycled, stopping when inspiratory flow drops to about 25% of peak. This prevents overinflation. Pressure support is not suitable for apneic or deeply sedated patients. It requires intact respiratory drive. Volume support ventilation automatically adjusts pressure support to achieve target tidal volume. It reduces manual ventilator adjustments. The ventilator monitors tidal volume over several breaths and increases or decreases pressure support accordingly. If patient effort increases, the ventilator may reduce support and cause dysynchrony. Careful monitoring is required. Weaning continues as pressure support requirement falls below 10 centimeters of water pressure. Spontaneous breathing trials are then performed. Ventilator mode does not determine recovery speed. Clinical readiness and respiratory strength drive liberation from support. Key principle is matching ventilator support to patient demand. Both under-support and over-support can cause harm. Final takeaway is simple. Mechanical ventilation is a dynamic interaction between machine settings and patient physiology.